Hello everyone, so I'm going to talk about my comprehensive care project. So patient is a 27-year-old white single male. His occupation is computer software engineering. Patient medical history. So patient was diagnosed with stress, anxiety and depression since 2020. His BMI is 32.1, which put him in obesity category. He has a history of smoking for 9 years and he's currently smoking 10 to 15 cigarettes in a day. He has a family history of cancer, no allergies, and his last physical exam date was June 2022. His baseline vital signs: blood pressure was 110/70, pulse was 76, respiratory was 14, temperature 96.8, and oxygen 97. His ASA status is 2. So patient is currently taking 2 medication. He's taking citalopram and fluoxetine 20 milligram each. He's taking one in the morning and one at night for his anxiety and depression. They have no effect on local anesthesia or vasoconstrictor. Some of the dental implications for these medications are xerostomia, abnormal taste, bruxism, and it may also impair platelet aggregation. Patient dental history. Patient never received dental hygiene treatment before. Also, patient does not have any history of dental treatment at all. Patient stated that he has bleeding when brushing or flossing his teeth and sometimes he is experiencing dry mouth. His chief concern is his teeth appearance. Extraoral and intraoral examination was within normal limit. Occlusal classification: he has class 3 malocclusion on both right side and left side canine and molars. Maximum opening is 50 mm. Overjet and overbite are 0, which represents the edge to edge bite. He has generalized crossbite in anterior teeth and open bite generalized in both anterior and posterior teeth. Facial profile is mesognatic and his TMJ is normal. For gingival description: free gingiva is pink, soft, edematous, shiny, knife edge in anteriors and blunted in posteriors. Attached gingiva is pink, smooth, and shiny. These are the intraoral photos both before and after the disclosing solution. Periodontal assessment. There is generalized BOP in posteriors. Marginal bleeding index is 68%. Plaque index is 82%. There is no mucogingival involvement, no mobility, no fremitus, and no history of caries or any restorations. So this is the probing sheet. There is a generalized 4 to 5 mm pocket depth in the posteriors and localized 6 mm pocket depth on number 17, 18, and 29. Anteriors, there is generalized pocket depth of 2 to 3 mm and localized 4 mm on number 6, number 10, and number 11. There is no recession. However, patient has pseudo pockets of 1 to 2 mm in the posterior teeth and the generalized interdental cal is 3 to 4 mm. The patient has no tooth loss. The cal code is 4 medium. There are class 2 forcation noted on buccal surfaces of tooth number 18, 19, 30, and 31. So here is the FMX of the patient. So it shows that there is generalized horizontal bone loss. Also there is localized slight vertical bone loss around tooth number 17 and number 32. There's also mesial drift on number 17 and number 32 mandibular third molars. And crown to root ratio is generalized 1 to 2, localized 1 to 1 in mandibular anteriors. There is one widened PDL on tooth number 2, number 3, 8 and 9, 14, from number 20 to number 29, and also number 31. And also there are generalized fuzziness in the radiograph that shows active periodontal disease. And there are radiographic calculus in all posterior teeth. Patient AAP periodontal classification is stage 2 periodontitis due to generalized horizontal bone loss that is only coronal third of the teeth and probing depth of 5 millimeter or less, and there's only localized 6 millimeter probing depth on distal lingual of tooth number 17, 18, and 19. The grading is grade C because the patient smokes 10 to 15 cigarettes per day, and the overall prognosis of the patient is poor. Oral hygiene evaluation prior to the treatment. Patient skill level is poor. He's not flossing or brushing regularly. He's not using any mouth rinse. However, he doesn't have any active decay and he has no history of restoration. He smokes 10 to 15 cigarettes a day. He grinds nocturnally, drinks soda every day. Patient complains about dry mouth, and patient has visible calculus on both radiograph and clinically. His camera is moderate. Patient nutritional analysis indicate high consumption of carbohydrates and sugary products. Patient does not perform daily exercise and is not consuming enough water. Patient also does not have any dietary consideration and his BMI is 32.1. Some of the recommendation to the patient was to include more protein, fruits, and vegetable in his diet, consume less added sugars and carbohydrates, lessen sodium intake, reduce soda intake, increase daily water intake, reduce alcohol consumption, and add physical activity to daily routine. Some of the recommended oral hygiene instructions to the patient was brushing 2 times a day using Bass method technique and fluoridated toothpaste for 2 minutes, and also use tongue scraper. Interdental cleaning was recommended to the patient, such as C-shaped flossing and proxy brushes. Act alcohol free mouth rinse and hydrogen peroxide mouth rinse was recommended to the patient. Also, N-Tuff toothbrush was recommended to brush the hard to reach areas such as third molars. Some of the other recommendations was sodium fluoride varnish after the dental hygiene treatment. For xerostomia, xylitol gum and biotin lozenges was recommended. Night guard was recommended since the patient has grinding habits. So there are some systemic risk factors that are related to patients' oral health, such as stress, obesity, smoking, and alcohol consumption. So patient was diagnosed with chronic stress since 2020, and stress can increase cortisol, suppress inflammatory responses, and it can also cause health impairing behaviors such as poor sleep, poor diet, poor oral hygiene care, and eventually increase risk of chronic disease. Patient also has a BMI of 32.1, which can increase susceptibility of chronic systemic condition and also periodontal disease. Patient smoked 10 to 15 cigarettes a day, and smoking can increase keratinization, vasoconstriction, dry mouth, dental staining, halitosis, and people that usually smoke have greater odds for severe attachment loss and also greater risk of getting cancers. And consuming more than 5 alcohol drinks in a week increased severity of periodontal disease, gingival bleeding, attachment loss, and biofilm accumulation. Some of the suggested referrals were oral surgery for third molar extraction because they are mesially drifted. Ortho referral was suggested since patient has class 3 malocclusion, edge-to-edge bite, open bite, cross bite, and crowding, and he's also concerned with his teeth appearance. Night guard was recommended. Smoking cessation was recommended since patient smokes 10 to 15 cigarettes a day, and patient is also interested in quitting, but he stated that he can't overcome cigarette craving, and smoking cessation can help him with that. Also, stress therapy and counseling was recommended to the patient. Dental hygiene treatment plan was a scaling and route planning by quadrants in 4 different appointments, along with local anesthesia and possible night rest if it's needed. Also, OHI was given in each appointment, and 4 to 6 week re-evaluation was indicated to scale the residual calculus and also applied sodium fluoride varnish. Some of the main treatment plan goals were elimination of periodontal inflammation, improve clinical status, prevent the recurrence of periodontal disease, improvement in patient knowledge, and behavioral modification and lifestyle changes. For re-evaluation, there was only a localized BOP on number 2, 15, 18, and 31. Plaque index was 4%, and there was no marginal bleeding index. So these are the probing depths. It was generalized 2 to 3 millimeter in the anteriors and generalized 3 to 4 millimeter in the posteriors. There was only localized 5 millimeter and 6 millimeter pocket depth in the posteriors around the third molars. Gingival description: for free gingiva, it was pink, firm, shiny, knife edge in the anteriors and blunted in posteriors. For attached gingiva, it was pinkish white, firm, and stippled. So these are the intraoral pictures both before and after the disclosing solution. As you can see, even after putting the disclosing solution, there's not much areas that are affected by plaque, and that shows the improvement of patient in his home oral hygiene care. So the overall result was good. The tissue color was pink and healthy. BOP was very minimal. There was 1 to 2 millimeter reduction in pocket depth. PFI was 96%, and also the patient stated that he's feeling better about his smile. Thank you all for watching my video.